Welcome back to Hot Mess, Not Your Mother's Midlife. Today we're talking about hormones, not just one. Last week we talked about progesterone, and today we're going to talk about estrogen, testosterone, DHEA, and pregnenolone, and why midlife can suddenly feel like your body stopped following the rules you lived by for 40 plus years. So we might be getting a little sciencey, because this is one of the most confusing stages of life for women. You start noticing changes and nobody really explains them in a way that makes sense. You feel hotter and not in a good way. You're more tired, you're more emotional, less resilient. Your sleep's disrupted, your body composition changes, your libido changes, your brain feels slower, your joints ache more, your recovery is different. And it can feel like you woke up in someone else's body. And then you go looking for answers, and what you find is noise. So you hear like hormones fix everything. Hormones are dangerous. You need testosterone, you need pellets, you need progesterone, you need DHEA, you need adrenal support, you need supplements, you need detox, or you're just told it's aging and you should deal with it. And none of those answers are helpful. What's helpful is understanding that hormones do change in midlife, but what is not really talked about is that they're only one part of the picture. Your nervous system changes, your sleep changes, your stress load changes, muscle mass, recovery, your life changes. And all of that affects how you feel. So today I want to just slow this down and talk about what estrogen actually does, and testosterone and DHEA and pregnenolone, what the research actually says, and why midlife symptoms are usually not one thing, but a combination of physiology, your lifestyle, and the stage of life you're in. So the goal is not fear, it's not hype. The goal is not to tell you you need hormones or that you should never use them. The goal is just understanding, because when we understand what's happening, we stop blaming ourselves. And that in itself is incredibly relieving. And one of the biggest misconceptions about menopause and midlife is that it's just about period stopping, and it's not. Hormones affect almost every system in the body. Estrogen, progesterone, testosterone, and adrenal hormones all interact with your brain, the bones, blood vessels, your skin, muscles, the nervous system, immune system, and metabolism. So when those levels change, you don't just notice one symptom, you notice changes everywhere. And research reviews on menopause physiology describe estrogen as influencing multiple tissues, including your central nervous system, cardiovascular system, bone, connective tissue, and urogenital tissue. That's why midlife doesn't feel like it's just one isolated problem. It feels like your entire system shifted. And the hardest part for a lot of women is that these changes don't always happen at once. Perimenopause can last years. Your hormones go up and down. Some days you feel normal and great. Some days you feel like your body's falling apart. That inconsistency is not weakness, it's the fluctuation. And fluctuation is very normal in this transition. So let's start with estrogen, because estrogen is the hormone that everyone talks about. It gets the most publicity. And it's also the one that's really misunderstood. And when we say estrogen, we're actually talking about a group of hormones. But for today's conversation, what matters is that estrogen helps regulate many different systems in the body. It affects temperature regulation, brain function, collagen, bone remodeling, blood vessels, skin, vaginal tissue, urinary tissue, mood, sleep, metabolism. I mean, it's like a scroll of things, right? That's why when estrogen starts changing, you don't just notice one thing, you notice many things at the same time. So during the transition, estrogen doesn't drop in a straight line. It's not linear. It fluctuates. And sometimes it's really high. Sometimes it's low. Sometimes it's unpredictable. Statements from the Menopause Society explain that perimenopause is characterized by hormonal variability before levels stabilize at a lower range after menopause. So that variability is one reason women feel like they can't figure out their body anymore. You think, why am I fine one day and I'm exhausted the next? Why can I sleep one night and not the next? Why am I suddenly sweating all the time? Why am I more emotional? Why does my body feel different? Not because you forgot how to take care of yourself, but because your internal environment has changed. So the machine's changing. And when that internal environment changes, your body needs different support. One of the most classic estrogen-related symptoms is hot flashes and night sweats. These are called vasomotor symptoms, and up to about 70–80% of women experience them during this transition, according to large population studies. They're not just feeling warm, they're related to how estrogen affects the brain's thermoregulation center. And research also shows that when estrogen levels fluctuate or decline, the hypothalamus becomes more sensitive to small changes in body temperature. The thermoregulatory neutral zone gets narrower. That means even a small increase in core temperature can trigger the body to react as if it needs to cool down fast. So you get that flushing, sweating, heart pounding, sometimes chills afterwards too. And this is why a room can feel fine 1 minute, and the next minute you feel like your body thinks you're standing in direct sun. You're not imagining this. You're not dramatic. This is the physiology of it. The Menopause Society also states that estrogen therapy remains the most effective treatment for moderate to severe vasomotor symptoms when it is appropriate and not contraindicated. But that doesn't mean hormones are the only factor. Sleep, alcohol, stress, caffeine, hydration, the nervous system, all that can influence how intense these hot flashes feel. This is why two women with the same hormone levels can have completely different symptoms. I mean, think about that. Think about when you're maybe panicking or you're having anxiety issues or you're stressed out and you feel that flush come over you, or you feel like it's like an inner furnace from the inside out. That can be completely different for someone else. The hormones matter, but the context matters too. So one of the symptoms that scares us the most is brain fog, losing words, forgetting things, feeling slower, trouble focusing, difficulty multitasking, feeling like your mind isn't as sharp as it used to be. And many women worry that this means something serious. But research shows that cognitive changes during menopause transition are very common and usually remain within the normal range. The estrogen interacts with neurotransmitters in the brain, including serotonin, dopamine, and acetylcholine, which are involved in mood, attention, and memory. Reviews on menopause and cognition describe estrogen as influencing multiple brain systems related to memory and emotional regulation. So when estrogen is fluctuating, you might notice changes in mental clarity, verbal recall, concentration, stress tolerance, emotional stability. But the part that matters is brain fog is rarely just estrogen. It's usually estrogen plus sleep disruption, stress, night sweats, life overload, under recovery, lack of self-care, sometimes under eating, sometimes too much caffeine, plus the emotional load of all the changes in midlife. And that combination makes the brain feel overwhelmed, not broken, overloaded. And when women hear that, it's like, what a relief, right? Because the story changes from I'm losing my mind to my body and brain are under more pressure right now. And that's a very different story. So let's talk about a part of estrogen decline that does not get talked about nearly enough. Tissue changes. Estrogen helps maintain the health of vaginal tissue, vulvar tissue, and the lower urinary tract. So when those estrogen levels fall, those tissues become thinner, drier, less elastic, and more fragile. Symptoms can include dryness, burning irritation, pain with sex, urinary urgency, recurrent urinary tract infections, and feeling like the tissue just isn't the same anymore. And a lot of women are told that this is just aging. I love that gaslighting. Or they're told to use lubricant or drink more water or relax. But this is not a comfort issue. This is tissue physiology. Estrogen affects vaginal tissue partly by influencing blood flow, collagen content, and the microbiome environment. Reviews on menopausal tissue changes describe significant decreases in collagen and connective tissue integrity after estrogen decline. That's why things can feel different. Not because you're imagining it, not because you're doing something wrong, because the tissue itself has changed. And this is important to say clearly. There are treatments for this. Local estrogen therapy, vaginal DHEA, and other options have strong evidence for improving symptoms when appropriate. Again, when appropriate. The Menopause Society supports low-dose vaginal estrogen as safe for many women, even when systemic hormones are not used. And women deserve to know that. I mean, I can't say it enough. Comfort matters, function matters. It's your quality of life, and that matters. And when you're suffering in silence, it's not a badge of honor. Estrogen also plays a role in collagen. That is what gives structure to skin, to tendons, ligaments, and connective tissue. After menopause, the collagen content can decline faster. Some studies estimate that women may lose a significant percentage of skin collagen in the first 5 years after menopause. And that can show up as more wrinkles, looser skin, more joint stiffness, aches and pains, slower recovery, feeling less resilient physically. And this is a time also when workouts can feel different. It's not that you're out of shape. It's just sometimes your tissue is actually different. And that means recovery, strength training, and nutrition becomes more important than they were before. Recovery, number one in my book. Not because you're weaker, it's because your body needs different support now. So let's talk about bones. Now we're talking about muscles, let's talk about bones. Because this is one of the biggest long-term effects of estrogen decline, because estrogen helps regulate bone remodeling. Your body is constantly breaking down bone and building new bone. And estrogen helps keep that process going, keeps it balanced. But after menopause, bone breakdown can outpace bone formation. This leads to osteopenia, osteoporosis, increased fracture risk. Guidelines from menopause and endocrine societies state clearly that estrogen therapy helps prevent bone loss while it is being used. But hormone therapy is not the only way to protect bone. Strength training, adequate protein. We need more protein at this stage of life than we've ever needed. Calcium and vitamin D mattered. Sleep matters. Balance and stability matters. Screening matters. The frustrating part about bone loss is that you don't feel it. You don't know what's happening. Nobody gets a warning. You don't get a message that says your bone density is changing while you're busy helping everyone else. And that's why midlife is such an important window for paying attention to strength and structure. Not for appearance, for function, for independence, for long-term health. I think we get to this age and we are beginning to be more accepting of where we are and not sweating the small stuff. Pardon the pun for sweating, but it's the truth. I mean, we have to take care of our bodies more than ever at this stage of life so that they can continue to carry us through life, as I say, rather than someone else carrying us. Think about that. I also want to talk about something really important that's usually very poorly explained, and that's the root of estrogen. So not all estrogen therapy works the same way. Two of the main systemic routes are oral estrogen, which you swallow, transdermal estrogen, which goes through the skin as a patch, gel, or spray, or a cream. And why does it matter? It's because oral estrogen goes through the liver first. This is called first pass metabolism. When estrogen goes through the liver, it can affect clotting factors and certain proteins in the blood. Transdermal estrogen largely bypasses the liver initially. And because of that difference, risk profiles can be different. Observational studies have shown that oral estrogen is associated with a higher risk of venous thromboembolism. Say that really fast. Compared to the transdermal, the skin, the estrogen. Another large study published in 2019 found that transdermal estrogen appeared to have little or no increased clot risk compared to oral forms. It's also noted that oral estrogen may have more effect on clotting markers, while the transdermal routes may have less. That does not mean transdermal is risk-free. It does not mean everyone should use a patch. It means the method is part of the conversation. And this is where optimal care matters, because the conversation should sound like this. What symptoms are you having? What are your goals? What is your medical history? What are the risks? What is the most sensible route if it's appropriate? Not hormones are dangerous. Not everyone should take hormones. It's individualized care. It's an adult conversation. That's what women deserve and need. But there's also an important safety point to mention. If a woman still has a uterus and is using systemic estrogen, she usually needs endometrial protection. That typically means progesterone or another progestogen. Unopposed estrogen can increase the risk of endometrial cancer. This is just basic safety, and it's another example of why hormone therapy should not be a casual fix-all, trend-based. It should be guided. It should be informed and monitored. One of the most interesting ideas in menopause medicine is the timing hypothesis. This idea suggests that the effects of estrogen therapy may depend on when it is started relative to menopause. And one of the key studies here is the ELITE trial, which was published in the New England Journal of Medicine. Researchers looked at women who started estradiol within 6 years of menopause and women who started 10 or more years after menopause. They measured progression of atherosclerosis using carotid artery thickness. What they found was that women who started earlier had less progression of arterial thickening compared to the late start group. So this does not mean estrogen is a heart drug. It does not mean everyone should take hormones. It does suggest that timing may influence risk and benefit. Modern menopause guidance reflects this idea. For many women younger than 60 or within 10 years of menopause, the benefit-risk profile may be more favorable than for women starting much later. This is where nuance really matters, because for years we heard one message: hormones are dangerous. And now sometimes the message is the opposite: hormones fix everything. The truth is much more complicated. Timing matters, dose matters, the way you're taking it matters, symptoms matter, your history matters, and women deserve conversations that can hold that complexity. So now that we've talked about estrogen, here's the other hormones that get a lot of attention: testosterone, DHEA, and pregnenolone. These hormones are often discussed together. Sometimes they're called the adrenal hormones. Sometimes they're called androgen hormones. Sometimes they're called the hormone stack. And this is where things can get very confusing very quickly, because the internet often makes it sound like if you just add the right hormones, everything goes back to normal. No, it's not adding spices to your chili. Physiology is not that simple. So let's talk about testosterone and what it actually does in women and what the research says, and why libido, energy, and motivation are not always just a hormone problem. So now, after talking about estrogen, testosterone has gotten even more publicity lately. You see ads about it, you hear clinics talking about it, you see women online saying it changed everything, other people saying it's dangerous, and somewhere in the middle of all that are women who just want to understand why they don't feel like themselves anymore, and why the libido changed, why motivation is much lower or not there at all, and why the energy feels different, why your body feels less responsive, why their drive feels off. So talking about testosterone today, I don't want to, it's not fear-based, it's not miracle-based, it's not marketing-based, but it's just what we actually know. And it's one of the biggest misconceptions about testosterone is that it's a male hormone. We make it too. It's produced in the ovaries, the adrenal glands, and also formed from precursor hormones in tissues. Interesting fact, testosterone is the most abundant biologically active androgen in women. Who knew? We always relate it to a male thing. Clinical guidelines from the International Society for the Study of Women's Sexual Health note that testosterone levels gradually decline with age, and this decline can begin before menopause. The decline's normal. It doesn't automatically mean something's wrong, but some women do notice changes that may relate to androgen levels, and they include lower sexual desire, reduced arousal, lower energy, less motivation, reduced muscle strength, feeling flatter emotionally, less sense of drive. But this is where we got to slow down about this, because not every symptom that feels like low testosterone is low testosterone. Midlife's complicated. Hormones change, sleep changes, stress increases, work demands increase, caregiving increases, marriage dynamics change, kids leave, parents age, bodies hurt more. You cannot separate libido from life, and that really matters. One of the main reasons women ask about testosterone is libido. Libido is not one system. Sexual desire involves the nervous system, hormones, emotions, relationships, relationship context, body comfort, stress levels, sleep quality, past experiences, your physical health. Research on female sexual desire shows that multiple neurotransmitters are involved, including dopamine, serotonin, and norepinephrine, as well as hormonal signals, including androgens. Testosterone can play a role in desire, but it's not the only driver. And this is where we get frustrated, because they want a simple answer. We want a simple answer. It's like, take this and everything's going to come back. Your muscle tone, the belly's flat, you're, feeling amorous again. Sometimes it doesn't. And sometimes the reason it doesn't is not hormonal at all. It's exhaustion. It's resentment. It's pain. It's feeling disconnected. It's feeling out of touch. It's like your body belongs to everyone else but you. So you can't hormone your way out of chronic stress. You cannot pellet your way out of emotional overload. You cannot supplement your way out of a nervous system that never gets to relax. That doesn't mean testosterone doesn't play a role. It means that the role has to be understood correctly. And it really helps to look at real guidance. So the 2021 clinical practice guideline from the International Society for the Study of Women's Sexual Health states that testosterone therapy is recommended only for postmenopausal women with hypoactive sexual desire disorder after proper evaluation. Not for fatigue alone, not for weight loss, not for anti-aging, and not for general wellness, not for everyone over 40. It's specifically for HSDD. This is defined as persistent lack of sexual desire that causes personal distress and is not explained by another condition, no medication, relationship issue. So that distinction really matters, because, we're on Dr. Google all the time, and, it makes testosterone sound like a general vitality hormone for women. But the strongest evidence is for sexual desire disorder. That does not mean other benefits never happen. It means the evidence is strongest for libido, and good medicine follows evidence, not trends. Randomized trials and meta-analysis have shown that physiologic testosterone therapy can improve sexual desire, arousal, and satisfaction in some postmenopausal women with HSDD. But there are important conditions. The levels should stay in the normal female range, not male range, not bodybuilder range, not as high as possible, physiologic range. Because when levels go too high, side effects increase. Use the lowest effective dose, monitor your labs, avoid supraphysiologic levels. That is the key phrase. Supraphysiologic. Higher is not always better. More is not always better. And this is where problems can happen when therapy is not monitored carefully. Testosterone therapy should not be guesswork. Guidelines recommend actually measuring testosterone levels before starting treatment and checking again after starting. Monitoring helps reduce the risk of side effects like acne hair, scalp hair thinning, voice changes, mood changes. Most of these are dose related, and some can be irreversible if levels stay too high for too long. And this is why careful dosing matters. It's not unsafe when it's used appropriately, but it's not harmless if it's used carelessly. And women deserve honest information about that. And that's where the conversation can get uncomfortable, but it's also really important. Some women are receiving doses that push their levels above the normal female range, and this can happen with pellets, high-dose compounded creams, or just poorly monitored therapy. I personally get my hormones checked every 6 months. I started every 3 months for the first year that I started with my doctor, just, in the last couple of years. And it took a while to get it put up, put up to the levels that she felt were good, that I felt symptomatic. Things I didn't feel symptomatic, things felt better, they were improving. But you have to check your levels because otherwise you're just feeding something that you may not need and causing complications later on. It's cautioned against the supraphysiologic dosing because long-term safety data is limited. That doesn't mean every woman using pellets is doing something wrong. It means the evidence is not strong for very high levels in women long-term. So it's like we don't know what we don't know. And I think medicine needs to be more honest about that. And not alarmist, not dismissive, just honest. We deserve informed decisions, not marketing, not Instagramming, not influencers. So I also want to talk about something that doesn't show up on a lab report, and that's libido. It doesn't exist in isolation. You can have normal hormones and no desire. You can have low hormones and still have desire. You can have perfect labs and feel completely disconnected. And why is that? It's because desire lives in the brain as much as in the ovaries. Chronic stress lowers desire, poor sleep lowers desire, pain, overwhelm, emotional disconnection, feeling like your body is another responsibility. I mean, that all but lowers your desire to do much of anything. And this is one of the most important things women need to hear is not every libido problem is a hormone problem. Sometimes it's a life problem, a relationship problem. Sometimes it's a nervous system problem. Sometimes it's exhaustion. Often it's all of the above. And if we ignore that, we miss the real solution. This is where I always want to come back to the basics. Not because basics are boring, but because they work. Things that support libido and energy indirectly, like strength training, adequate protein, sleep consistency, stress regulation, self-care, less alcohol, better blood sugar balance, more recovery, more connection, and less overload. None of those are magic. It's easier said than done, but that is how it changes the body. Hormones can help, lifestyle helps, emotional health helps. It's a combination now that we need to talk about more often and really tap into. Another hormone that gets mentioned all the time is DHEA. And this one's often called an adrenal hormone. It's often sold as energy support. It's often blamed when we feel exhausted. It's also one of the most misunderstood hormones. So let's talk about what it actually is, what it does, and why the idea of adrenal fatigue is not as simple as people think. You may hear things like your adrenals are burned out. I subscribed to that for years and years. Your DHEA is low. You need adrenal support. You should take DHEA after 40. DHEA will help your energy. DHEA will balance your hormones. And a lot of women are left thinking, what is DHEA? Do I need it? Is this normal? Is something wrong with me? So we'll slow it down again and talk about what it actually is. I'm not going to give you the marketing version. I'm giving you the physiology version. It's a hormone produced mainly by the adrenal glands, with smaller amounts made in the ovaries and in the brain. It's called a precursor hormone, and that means the body can convert it into other hormones when needed. Those include testosterone, estrogen, and other steroid hormones. It means the hormone is converted inside tissues, not just in the bloodstream. Reviews in endocrine physiology describe DHEA as part of a complex hormone pathway that depends on tissue needs, enzymes, age, and health status. So when people say your DHEA is low, the real question should be low compared to what? Low for my age? Low compared to a 25-year-old? Low in the lab range? Low in causing symptoms? Or just lower because you're not 30 anymore? Because it does naturally decline with age. The levels are highest in our early adulthood and gradually decrease across the lifespan. So the decline is normal. It doesn't automatically mean something is wrong, just like I've said with all the other ones. But it also doesn't mean that you need supplementation, because DHEA can be converted into other hormones. It can influence multiple systems indirectly, like mood, energy, sexual function, bone, skin, immune activity, metabolism. But the key point is it's not always the active hormone. It's more like a raw material. The body decides how to use it, when to use it. And that means taking DHEA does not always produce predictable results. Some people feel better, some people feel nothing. Some get side effects, because once DHEA enters your body, it can be converted in different ways depending on the person. Again, this is why these general blanket recommendations about DHEA can be misleading. It's not a one-size-fits-all hormone. None of them are. But one place where DHEA actually has good evidence is vaginal use. Now, this is new to me. There's a form of vaginal DHEA called progesterone that is approved for treatment. When it's used locally, DHEA is converted inside vaginal tissue into estrogens and androgens right where they are needed. Studies show this can improve dryness, pain with intercourse, tissue elasticity, lubrication, and because the conversion happens locally, systemic hormone levels may not increase very much. There's some statements from menopause organizations that support vaginal DHEA as an option for moderate to severe tissue symptoms. This is a good example of targeted treatment, not hormones for everything, hormone for a specific problem. And that is what good medicine looks like to me. So let's talk about one of the biggest sources of confusion around DHEA, adrenal fatigue. How many years have you heard that? I started hearing that in like 2003 or 4. You know, the phrases like my adrenals are burned out, they're exhausted, my cortisol is low, I need adrenal support, I need DHEA for my adrenals, I need every book out there on adrenals, I need to make adrenal soup. The problem is that adrenal fatigue is not a recognized medical diagnosis. Major endocrine organizations state that there is not scientific evidence supporting adrenal fatigue as a defined condition. So that just blew my mind when I found that out. But that doesn't mean people aren't exhausted. It does not mean that stress doesn't affect the body, because it absolutely does. But the explanation is usually not that the adrenal glands stopped working. True adrenal insufficiency is real, but it is rare and requires a proper diagnosis. Most midlife fatigue is more likely related to things like poor sleep and stress and the perimenopause and the whole overtraining, undereating, thyroid issues, iron deficiency, life overload, mood disorders, lack of recovery. I mean, on and on and on, right? And when the explanation becomes your adrenals are tired, take the supplement, we are maybe missing the real cause. That's why I always want women to hear this. Feeling exhausted does not mean your hormones are broken. Sometimes it means your life is full. Sometimes it means your body is under-recovered. Sometimes it means your nervous system never gets to turn off. You know, grinding it out and being busy every second of the day is not a badge of honor. Sometimes it means you need support, not supplements. DHEA is available over the counter in the United States, and that makes it seem harmless, but it's still part of the steroid hormone pathway, and that means it can change hormone levels. Some studies show that oral DHEA can increase androgen and estrogen levels in some people, but the responses are very, very much widely varied. Long-term safety data is limited. Side effects can include acne, hair growth, oily skin, mood changes, changes in cholesterol, hormone imbalance, because once you take a precursor hormone, the body may convert it in ways that you don't expect and maybe that you don't need. It doesn't mean that it's bad, that DHEA is bad. It means it's not neutral. And us midlife women are often offered supplements before anyone looks at the other things like sleep and stress, nutrition, workload, family life. This is the approach I think that makes the most sense. Instead of asking what hormone should I take, ask what symptoms am I having? Dryness, low libido, fatigue, mood changes, poor sleep, brain fog, pain, low strength, lack of motivation, and then ask what could be causing this. Is it hormones? Is it stress, sleep, nutrition, relationship strain, burnout, medical issues, life overload? now match the treatment to the symptom, not the other way around. Because chasing hormones without context can lead to taking 5 things when you only need 1 or nothing at all. This is where I always come back to the same foundations, not because they're trendy, but because they work. Our midlife bodies need strength training, adequate protein, sleep consistency, hydration, stress regulation, recovery, blood sugar stability, and less of the all or nothing dieting. You know, we need to be supporting ourselves with balance. And that supports our nervous system. It supports energy. Hormones can help, but the foundation still matters. So there's one more hormone we need to talk about, pregnenolone. This one is often called the mother hormone, the master hormone, the captain of the ship, the hormone everything comes from. And whenever a hormone gets that many titles, we really need to slow it down because usually the truth is more complicated. So we'll talk about, again, what it actually does and why stacking multiple hormones is not always the answer. I take pregnenolone and I've noticed that I've evened out. This hormone, it's the stress hormone, right? It's the anti-aging hormone. Pregnenolone is a steroid hormone made from cholesterol. It's produced in the adrenal glands, the ovaries, and in the brain and nervous system. It's also called a precursor hormone. So it converts into other hormones, much like our friend DHEA. That can include progesterone, DHEA, testosterone, estrogen, and cortisol. Because of this, it sits near the top of the steroid hormone pathway, and that's why people call it the mother hormone. But that name is misleading. Just because it sits upstream does not mean taking pregnenolone will automatically fix everything. Downstream. Hormone pathways are not assembly lines. They are dynamic systems. The conversion depends on enzymes, tissues, age, stress level, health status, genetics. Endocrine research describes pregnenolone as part of a tightly regulated system, not something the body just turns into whatever it wants. So the idea that you can take pregnenolone and balance all your hormones automatically is a complete oversimplification. One reason it gets the attention is because it's also a neurosteroid, which means it acts in the brain and nervous system, not just in the endocrine system. Pregnenolone and its metabolites can affect neurotransmitters like GABA and glutamate, which are involved in mood, anxiety, and cognition. The research on neurosteroids shows that pregnenolone may influence memory, focus, stress, response, sleep, emotional regulation. And this is why people connect pregnenolone with brain fog and mental fatigue, the wired and tired, feeling overwhelmed. And those symptoms are very real in midlife. But the question is always, is pregnenolone the cause, or is it part of a bigger picture? Because brain fog in midlife can also come from sleep disruption and perimenopause stress, hot flashes, low iron, thyroid issues, life overload, under recovery. Hormones tell a story. They're not always the whole story. You may have heard a phrase called the pregnenolone steal. Now, this idea says that when you're under chronic stress, the body diverts pregnenolone toward cortisol production and away from the other hormones. The scientific evidence for this exact mechanism in humans is limited. The literature in endocrinology, it does show that stress affects the HPA axis, the hypothalamic pituitary adrenal system. But the simplified idea that stress steals all your pregnenolone and causes hormone collapse is strongly supported. It's not strongly supported. The body is not running out of hormones like gas in a tank. It's adjusting signals in complex ways. And when the explanation becomes too simple, the treatment also becomes too simple. Take this, fix everything. Midlife physiology is rarely that simple, if only. Pregnenolone supplements are available over the counter, which again makes them seem harmless. But like DHEA, Pregnenolone is part of the steroid hormone pathway, like I said earlier. And once you add a precursor hormone, the body may convert it in ways that are not necessary. And the studies on supplementation are limited. Some research has looked at pregnenolone for mood disorders, cognitive issues, and fatigue, but the results are mixed. The long-term safety data is not strong. Possible side effects could include irritability, insomnia, headaches, acne, hormonal shifts, mood changes. It doesn't mean it's bad. It means it's not magic. None of these hormones are magic. More is not always better. And we have to just keep that in mind. You don't need to add everything all at once, if at all. But it brings me to something that I'm seeing more and more, that women are being told they need estrogen, progesterone, testosterone, DHEA, pregnenolone, sometimes all at once. And sometimes it's appropriate. Often it isn't, because not every symptom comes from every hormone. And when you add multiple upstream hormones, it can become very hard to know what is helping and what is not. I'm a self-experimenter myself, and sometimes I play with it and see if I notice a difference. Maybe not taking one for a little while, seeing how I feel. Are there any side effects? Do I feel worse? Do I feel better? Guidelines for hormone therapy generally recommend targeting treatment to specific symptoms rather than stacking multiple hormones without a clear reason. Marketing is out there and it says, fix everything at once. Good care usually says, start with the problem you're trying to solve. And this is the approach that I come back to again and again. Instead of asking, what hormone am I low in, ask, what am I feeling? Is it brain fog? Is it low libido, dryness, fatigue, anxiety, bad sleep, low strength, mood swings? And then ask, what could cause this? Again, hormones, stress, sleep, nutrition, burnout, pain, life load, all of it. You got to match the treatment to the system, not the other way around. We end up chasing all of this and taking things that we don't need, or where we only need a little bit. So forget trendy. We need, again, my favorite things to say, we need strength training, adequate protein, sleep regulation, hydration, recovery, less all or nothing. These all support our hormone balance. They support our nervous system. They support energy and mood and libido, tissue health, our bones. They make us more resilient to the changes inside and out. All of this stuff helps. Taking care of yourself, your emotional health. If you take one thing from this episode, let it be this. Estrogen matters, testosterone matters, DHEA matters, pregnenolone matters, but it's not a magic potion. Midlife is not one hormone. It's the whole system changing. Your brain, your bones, your tissue, your nervous system, your stress load, your life. You're not broken. It's a recalibration, and it can feel super messy, uncomfortable. It can feel humbling for sure, but it can also feel powerful. It's very liberating, because this stage of life is not the end of your body. It's a transition into a different kind of strength, not the strength you had at 25, a different strength, more honest, more informed, more intentional. You're not too late. You're not done. And you're not required to suffer in silence just because nobody explained this to you sooner. This is your body. It's your next chapter, and you still get to build it with intention. This is your hot, messy midlife, not your mother's midlife. Thanks for listening. If this episode helped you, share it with a friend who's in this stage of life too, because midlife is easier when we stop pretending and start talking about what's real. You can find my courses and programs and more at BeRealBeHealthy.com, where I teach realistic strategies for hormones, health, strength, and feeling like yourself again during and after midlife. And if you enjoy this episode, make sure you follow the podcast so you don't miss what's coming next. Next few weeks, I will have some amazing guests telling their stories about midlife, menopause, reinvention, and pivoting in life when we think we're not able to. Think we're not good enough, or that if we have the strength. But until next time, take care of your body, protect your peace, and remember, this is not your mother's midlife. Take care.